Good afternoon, everyone. On behalf of McLaren Macomb, hello and welcome to this educational program on urinary incontinence. I'm Kelly DiNardo, your moderator. We will be hearing from Dr. Andrew Agosta from McLaren Macomb. And at the end of this presentation, Dr. Agosta will be answering any questions that you might have. Please use the chat feature to send in your questions. And so we'll go ahead and get started. Dr. Agosta, thank you so much for joining us today.
Thank you, Kelly. All right, hello everybody. I'm pleased to be here and be able to talk about this to you. Today's subject is urinary incontinence. It's going to be a general overview. I will go into prevalence, what causes the urinary incontinence, what types there are, and the distribution of those things. A little bit into the evaluation, and then I'm going to focus on the two most common types, and that's overactive bladder and stress urinary incontinence, and talk about conservative treatment and more aggressive treatments on each. And so we'll go ahead and get started. The first thing is, how common is urinary incontinence and why are we talking about it? Well, it's very common, and especially for women's care, it's more common in women than men. And over a third of patients over the age of 60 have issues with urinary incontinence, and so that's a very large number. The the incidence and prevalence of it does increase with age as well, and if you look at nursing homes, it's epidemic. 50% of the patients in nursing homes have difficulty with urinary incontinence, and oftentimes that's a cause for admission into the nursing homes. And so it is certainly out there. So when you look at prevalence of incontinence, we talked about it being more prevalent as you get older, but it's not just the prevalence of the incontinence, but prevalence of severe incontinence gets, increases with age as well. And so if you look at the bottom, can you see this pointer? If you look at the bottom green on the slide, you can see how that elevates as you get older, and that's severe incontinence. And so the next question is, if we know that it increases with age, well, how old is our population in the United States? And are there a lot of older individuals? And the answer is yes. In 1996, there was 33 million Americans over the age of 65, and it's projected that there'll be 69 million by the year 2030. And so if you look at a percentage of the population in 1996, only 13% was over age 65. It's projected in just a few years that'll be 20%, and by 2050, a third of our population will be over the age of 65. So it's all of the baby boomers that are now getting older. And so you can see that things like urinary incontinence are going to be prevalent for quite some time and increasing. How much does it cost? Well, it's considerable, $16 billion. The real problem with this is that the majority of this cost has to do with absorbent pads and garments as opposed to evaluation and treatment. And what's that cost in comparison to other illnesses and disorders? You can see it's still significant. It is, almost twice as much as what we spend each year in the United States on breast cancer. There are some contributing factors, and these are reversible causes for urinary incontinence. Certainly, it has the pneumonic diapers. Drugs, that would be number one. A lot of the pharmaceuticals and medications that patients are taking can affect the bladder. There are certain drugs called anticholinergic medication that causes problems with that can cause problems with the bladder. And a lot of the water pills or diuretics certainly are going to fill the bladder up and cause worsening of incontinence. And so it's important to make sure that the type of medicine you're on isn't causing a problem or that it's necessary. So for instance, water pills for high blood pressure is one form of treatment for high blood pressure, but there's a lot of different other avenues that someone can go in. And if your doctor is not aware of your bladder issues, they probably should try something different besides the water pill if that's the only reason for it. Infection or urinary tract infections can cause urinary leakage. The infection itself causes irritation and bladder spasms, and some of the bacteria have endotoxins that can relax the urethra. And so some people, part of their symptoms with a UTI is urinary leakage. Atrophy is a loss of hormones to the vaginal tissues. Delirium, endocrine is mainly diabetes. It's diabetes is polydipsia and polyuria, which is you urinate a lot and you drink a lot if it's not controlled well. And that means you're filling that bladder up continuously and increasing your symptoms. Restricted mobility, it could be that your bladder is doing fine, except the patient who needs that cane or the walker to get to the bathroom and it takes some considerable time may not be able to hold it that long. And stool impaction or constipation is another reason. The nerves that go to the rectum and the anal sphincters also are the same nerves that go to the bladder. And so constipation seems to have an effect on it as well. And all these things are reversible. Just as a side note, if you have issues with fecal impaction and constipation, you need to be able to treat that. I just saw someone recently that the normal bowel movement is every 7 to 10 days. So that's not healthy, and it's not, good for her leakage symptoms as well. And so, daily fluid intake, fiber supplementation, sometimes enemas. But I wanted to state that Miralax is a type of bowel medication that will take care of most problems with constipation. And this is something that you can take every day without hurting you. Your body doesn't get accustomed to it. And so you can titrate the dose to have 1 or 2 bowel movements per day or every other day. But this is part of having a bowel regimen so you don't run into problems with impaction and problems with your bladder because of that. So what types of incontinence are there? These are the most common. Stress urinary incontinence, or SUI, is the highest, and you can see the percentages there. The stress incontinence is really a loss of support, and it's loss of support to the urethra. The urethra is the tube you urinate through, and that's supported underneath the pubic bone. And if that support has weakened, allowing the urethra to fall away from its normal anatomical site, then urine is able to slip out. And these are oftentimes patients who say, I leak with activity, coughing, sneezing, laughing, those type of things. DO is detrusor overactivity. It oftentimes is also termed overactive bladder. And these are bladder spasms in which the bladder doesn't relax and just tell you you're full, I'm really full, I really have to go, but you lose control from the mind being able to tell the bladder to hold it and continue to relax, and the bladder just starts to squeeze even though you're saying don't do that. And so that's detrusor overactivity or overactive bladder, and 10 to 30%. Mixed pattern means combinations of things, and It's going to be overactive bladder with either stress incontinence or ISD. ISD is a subset of stress incontinence, and that stands for Intrinsic Sphincteric Deficiency. And really what that is stress urinary incontinence with a poorly functioning urethra. And so the urethra has to have a certain function to close and become watertight. So it makes a watertight seal. And if the urethra function is weakened, that seal becomes loose. And so it's like a bad washer where the urine can just kind of fall right through the urethra without much pressure at all. And that's a special category because that is a risk factor for failing a surgery. And all these things are treated differently. And that's the reason we need to know what type of incontinence you might have, because there are going to be certain treatments that are going to be better than others for certain types. And then occasionally we see other things like overflow incontinence. That's when the bladder is very large capacity. Typically you have a neuropathy, a problem with the nerves going to the bladder, and you lose your sensation to filling and you can't empty well. And the bladder just gets overfull, and it's like filling up your coffee cup to a point where it's just nowhere else to go except overflow. We don't see it very often, which is good. And same with diverticula and fistulas. A diverticula is an outpouching of the urethra that's surgically corrected. A fistula is a hole in connection from the bladder to the vaginal area. And those usually are complications of surgery. So the top ones are the ones we're going to talk about: stress incontinence, ISD, and detrusor overactivity. So the first thing we do when we have a patient coming to my office is we send them a urinary diary. And a diary is simply for them to write down the time they urinate and how much. We often will send them a urinary hat as well, which is a device you can place on the commode, and you can urinate into that so the urine is collected, and there are measuring lines so you can measure how much you go. And so you'll write down the time you went, how much you went, time, how much, and you keep that log. And you do 2 24-hour time periods. And we ask you to write down bedtime and wake up time so we know how many times you woke you from sleep. And from this, you can get a lot of information. We know what your frequency is. We know what your maximum urination is. We know how many urinations are small capacity. We can tell your output. And so surprisingly, we have patients and you say, well, I'm not sure why I'm going, 20 times a day. And we find out that, well, their output is 6 liters. And it becomes habit oftentimes. They may have started drinking a lot for dietary purposes, and then they get accustomed to it. And they're stressing their bladder when they do that. But this is a very simple way for me to gain a lot of information that may pertain to your case. In regards to the evaluation, some of the evaluation is very easy. And so there are a number of patients that simply by obtaining a good history and doing a physical examination, and then a few other maneuvers, we can come up with a diagnosis. And so, we oftentimes will test for post-void residual. And what that means is, we'll have you empty your bladder and see how well you emptied. So what it does is it rules out overflow incontinence. We test your urine for infection to rule that out. And if we can fill the bladder and demonstrate leakage with stress, such as coughing or bearing down, that may be all you need to come up with the diagnosis of stress incontinence. And then we can talk to you about what your treatment options are. There are some patients, however, that are more complicated, and the problem to some degree is that the bladder does not make a very good witness. So even though it can lead you into a certain direction, such as I have frequency, I have urgency, I have leakage with urge, those are more common symptoms with overactive bladder, or I have leakage with coughing, sneezing, lifting. That's more common with stress urinary incontinence. Oftentimes you have components of all that, with all the different types of incontinence. And so there are some cases that you say, I'm really not sure what's going on without doing additional tests. And so if we did do additional tests, that sometimes is looking inside the bladder with a telescope called cystoscopy. That's done in the office, and oftentimes something called urodynamics, which is bladder testing, again done in the office, but utilizing some small catheters. This is, what it looks like to have urodynamic testing. That chair actually is the chair that I use, and it's a great chair for different positions and, doing this type of work. But catheters are placed one inside the bladder, and so we can backfill the bladder, and a catheter is placed intravaginally. And with those, the pressures of the bladder and urethra and pressures from the abdomen as transferred to the vaginal area are being able to be recorded. And these catheters are very tiny. The catheters don't hurt, and the test doesn't hurt. They take about maybe 30 minutes, and we can gain an awful lot of information from them. This is an example of a printout of part of the test. This is called a Systometrogram. And as you move, let me see if I can do this. As you move from the left to the right, fluid is being inserted, okay? And your bladder is being filled. And we'll ask when it feels comfortably full, markedly full, when you feel like that's about all you can hold. And so we gain some information there. These lines, this is a cough. This is either the patient moving or talking, but you can see that this area here is the bladder pressure. This is the abdominal pressure, and most of these pressures coincide with each other. This is a computer-generated pressure to say, are these things really bladder contractions or just increased abdominal pressure from other things? And you can see that these are not bladder contractions, but this is. You see how that pressure went way up. Now, if it was during part of the test that we said, hold it, then that would be an abnormality, and that would be consistent with detrusor overactivity or overactive bladder. If it was part of the test that we say try to void or try to urinate, then that's a normal response that the bladder is trying to contract and squeeze the urine out. But this is what we gain in regards to performing those tests. So the first thing we're going to talk about is overactive bladder. The overactive bladder consists of symptoms of urgency, frequency. Nocturia is getting up at night, and with or without urge incontinence, meaning leakage with urgency, trying to get to the bathroom. If we look at the prevalence of overactive bladder, it's similar to incontinence in general, in that it increases with increasing age. Women are in the red, but you can see as you get older, the incidence does increase. And so with any type of incontinence, we have to ask, what are patients looking for? And really, and this is what we're going to try to deliver, is to regain freedom, regain control, confidence, body image, Patients want to be able to get back to doing their normal activities without the fear of an accident, the fear of, odor if you're sitting next to somebody. And they want to be able to do these things and have the confidence that they can. The second thing is, if an aggressive treatment is needed, such as a surgical treatment, well, they want that treatment to be minimally invasive, meaning easy, short, with minimal discomfort, and back to their normal activities, within a few days. And we can accomplish all of that. So the first thing that we need to talk about in regards to treatment of urinary incontinence is weight loss, because this uniformly helps most any type of cause for urinary incontinence. So obesity is certainly a strong independent risk factor for urinary incontinence. And we know that patients who undergo surgery and have bariatrics and they lose 100 pounds, their incontinence usually is markedly better. And but what is not known to most is that even if you have a mild or moderate amount of weight gain, just losing 5 to 8% of your weight is oftentimes very helpful. And so that may translate into 10 or 20 pounds, and that can help your incontinence. And so it should be the first thing that you consider doing if you're looking for a simple way of trying to improve your situation. Now, there are conservative treatments for overactive bladder. And, the first thing you need to know is that there are treatments that are easy, because a lot of patients don't really know that. They just think that surgery is the only thing you can do to help incontinence, and that's not true. And so the first thing is, we always talk about behavioral intervention, fluid consumption management. We want to take that patient who's putting out 6 liters and therefore drinking 6 liters a day to consume a normal amount. Most people have to push their fluids to try to get to 8 to 10 glasses a day, which most people would think that's the recommended, consumption. But there are some people that really are drinking 25, 30 glasses a day. And so we want to, for those patients, they need to cut that back. And then secondly, try to avoid bladder irritants, which oftentimes are caffeinated beverages, the coffees, the colas, the carbonated beverages, alcohol. Those are all sometimes irritants to the bladder, and they worsen your bladder symptoms. And then there are other things that we can do, such as bladder training, timed voids, and medication. So bladder training is an easy thing to do, except it takes a lot of motivation. And so it does work, but it is difficult for the patient to stick with. And so what this is basically trying to retrain your bladder to fill up more and more. And so what it is having urination starting at a couple of hours apart, or maybe an hour and a half apart, and then weekly increase by 15-minute intervals. And so, instead of going every hour and a half, after a week, you go to an hour and 45 minutes, after another week, 2 hours. And the goal is to get to 3 to 4 hour intervals in between, and to train your bladder to hold it longer so you don't leak before then. So it is something that you can do as a conservative means, although it does take some motivation. Timed voiding is just a little bit different, and this is actually very good for the elderly, the patients in nursing homes, the patients with dementia. And basically this is the caregiver or the family member just reminding mom or grandma, it's time to use the restroom, let's go, even if they don't feel that they have to. So basically every few hours saying, let's get up and let's use the restroom. And what they're doing is trying to keep the bladder more on the empty side, so they don't run into as many problems with the leakage when their bladder gets full. And then medications. And there's a number of medications on the market that do improve overactive bladder. This is a list of a number of them here. And they do work for the most part. There are some side effects. Most everybody will notice some dryness in their mouth with most of these medicines. However, most are tolerated just fine. The older ones are multiple times a day, 2 or 3 times a day pills. They have worse side effects than the newer ones, which are once a day pills. Those side effects are much better. They have much less problems with dryness in their mouth. And other things that can happen, they can cause constipation in some individuals. They will decrease the amount of perspiration, which usually isn't a problem unless you're training, you're an athlete and doing excessive training. And so for the most part, they're tolerable medications. And they do improve their frequency, the urgency, and the leakage with urge. There's one of the medicines on the bottom here, mirabegron. It's called Myrbetriq. That is the only one that is a different class of medication. That's not the same class as the others, and therefore that one does not have the dryness of mouth. Unfortunately, it's the only one in its class, and so there aren't any competitors yet, and so that is the most expensive, and oftentimes you run into some trouble with insurance coverage for that. But there are medications out there that can help, and for the majority of patients, these medications do work, and that's all you need to do. So we go through an algorithm, looking at the simplest things to do. We do conservative treatments. Oftentimes we'll move to medication, and oftentimes we'll follow up somewhere between 4 and 8 weeks. We'll do a urinary diary prior to medication so we know what the baseline is. We'll ask to come back in 4 to 6 weeks for a follow-up visit and bring in another urinary diary so we can objectively see whether or not there's been changes in the amount of frequency, the amount of small voids, and that sort of thing. Most everybody does well. We can change dosage if we need it to be a little bit stronger. We can decrease dosage if the side effects are a little bit too much, and majority of people do fine. But there is some that either can't tolerate the medicines for one reason or another, or the medicines are just not giving quite enough improvement for them to be satisfied. And for those patients, you have to get a little bit more aggressive when we do have some things to offer. So next, we're going to talk about some of the advances in the more aggressive treatment for overactive bladder. And this has to do with either Botox being administered in the bladder or something that's called neuromodulation. So Botox is, it's a toxin and it paralyzes muscle. Obviously, you've all heard, I'm sure, of Botox being used, in the face for wrinkles and that sort of thing, but there are a number of medical uses for it as well, and urinary incontinence is one. Again, this is for overactive bladder or bladder spasms, and we do this in the office with a cystoscope. So it's a small telescope. We place that in the bladder, and then we bring this through a needle through the cystoscope, and we inject a small amount of Botox at a number of different sites throughout the bladder. It only takes about 5 minutes. This is tolerated very well. We put some numbing medicine or lidocaine inside the bladder for about 15 minutes prior, so it kind of numbs the area. And so it's something that's very easy to do in the office and is tolerated very well. The procedure does work. And again, we're taking the patients that are mostly resistant to the normal types of treatment. And so this is the worst of the worst patient in regards to the difficulty in treatment. And the majority of those patients do quite well. So this is looking at Botox, looking at different dosing. And you can see the 100 unit is a small triangle. It comes right down here. And so it is just about as good as the other higher doses. And so that's why we usually will go with 100 units as our standard dose. We do increase dosage if there is another reason for the overactive bladder, such as a neurologic problem with MS or Parkinson's or stroke. But usually it's 100 milligrams. And you can see also that it lasts for, by 6 months or so, you're still pretty good, but then it starts to lose its effectiveness. And so most of these patients, we have them come back and we do injections every 6 months to keep their symptoms at bay. So advantages, it's a office procedure. Disadvantages, it has to be repeated typically every 6 months. There is an issue with some patients having difficulty urinating, and that's about 6% of the patients. Of those, it lasts a number of weeks and then usually will dissipate. Other side effect is that the chance of urinary tract infections go up with them as well. So the next thing is neuromodulation. And this is actually in deploying a wire next to the nerves that go down to the bladder and stimulating those nerves. And that tends to relax the bladder and causes lessening of their incontinence frequency and urgency. So this is somebody having a test in the office. And so one of the advantages on this is that there is a test in the office that you can do to see if this modality might work. And so what we do is we place a small needle and we place that right through the third opening in the sacrum, and that's the nerve that we want to catch right here. And so the way that we know that we're in the correct area is we stimulate. So we stimulate that needle that's next to the nerve, and this is what happens. You get certain responses. If we are up too high into the second foramina or the second area where the nerves pass, we'll get contraction of the calf muscle. If we're down too low, we won't get any flexion of the large toe. If we get that flexion and a bellow where it's contracting up near the anus and lifting and sensation going down into the rectal vaginal area, we know we're in the right spot. And so once we do that, we then hook up a temporary generator. So it's like a little beeper here. And this gets sent home with this, and we stimulate the nerves. And we have you come back about 3 days later and you do logs. And so we can then see whether it's improved. And if you had good improvement, then we know that this therapy should work for you. And so then the next thing we do is we bring you to the hospital for a small outpatient procedure. And it's just done under local, meaning some numbing medicine. We don't put you to sleep or anything, except this time we are going to implant a permanent battery. And so it's a small little thing in the upper buttock area that will stay there and stimulate those nerves continuously and to give you continuous type of treatment. Now, when we bring you to the hospital for this, we want to make sure that we have not just know that it works, but we want to be in the best possible spot and lay that wire right next to the nerve. And with that, or to do that, we utilize X-ray, so we know that this is the spot we want to be in, the third sacral opening, and we know by X-ray where that's located, and we can place the needle and find out exactly where it is. We can do lateral views then, and again, we know exactly where we're putting it, so it's in the proper position. And so when we're done, this is exactly where we want to be. In the third opening, this comes just a little bit medial to lateral, so it has a little bend to it, and this bends downward, and these are the areas that actually stimulate the nerves. Now, the battery is something that is, this gives you an idea of the size compared to a quarter. You can see what this size is. This is the, it's the older battery, and it's not that big, but it's a permanent battery. It will last 5 to 7 years. And so in the past, this is how we've always done it. And in 5 to 7 years, we pull that out and just pull unlodge the battery and connect another one, and just pop that back under the skin. The newer device now looks like this, and you can see it looks just maybe like a large flash drive that you would put into your computer. And so it's very small. And this just gets set underneath the skin, and this one is rechargeable. And so patients will put a little wireless charger, they put it on a little Velcro strap, and they will charge once a month for about 20 or 30 minutes, and that's all they need. And then if you use this one, that lasts for up to 15 years. In regards to the effectiveness, you can see that it doesn't work in everybody, and but we're talking about the most difficult patients. But on the other hand, it's 75 to 80% effective. These are the patients that are perfectly dry. These are the patients that are at least 50% or more improved. So I'm going to get to the last subject now, and that's stress urinary incontinence. So again, we'll start with conservative treatment. And again, know that there is conservative treatment available. The conservative treatment are things that are not very difficult. They're easy. Oftentimes, they're not going to cost you any money or not too much to pick up any kind of equipment. They all have to do with muscle exercises. And so the idea is, or most of them do anyhow, the idea is to build up the support of that urethra and try to limit the amount of leakage by doing that. And so Kegel exercises, most of you have probably heard that. Dr. Arnold Kegel came up with that many, many years ago, and it's still valid today. Vaginal cones, biofeedback, and then there's some things with urethra compression, such as over-the-counter inserts, pessaries, and bulking agents. And we're going to go through each of those now. So pelvic floor muscle training, these are Kegel exercises. And the goal is to squeeze the pelvic floor musculature. The issue with this is that a lot of patients don't really know where to squeeze. And so your provider can teach this to you with examination. And so what typically we'll do is we will pull on those muscles with a vaginal exam and teach you where the muscle is so you know what to squeeze to make sure you're doing them properly. Because oftentimes people will squeeze, they'll tighten their abs and they're tightening the buttocks, but they're not tightening the right muscles. Once you learn how to do them, then the idea is to exercise those muscles to strengthen them and then use them. And so what we ask you to do is squeeze as if you're holding your urine as hard as you can and hold. Hold, hold, hold. Try to get to a count of 10 if you can. And then squeeze, squeeze, relax. That's one contraction. And so you want to do 15 of those 3 times a day. You have to associate it with an activity, such as, the first 3 times you get into the car, something that you would do every day. If you do it that way, you'll do them. If you don't associate it with an activity, everybody forgets to do them. And so that's what I would recommend, is associate it with some sort of an activity you know you're going to do 3 times a day. And then what happens is, if you have to cough or sneeze, you squeeze. Then you can cough and relax. And that's just to try to give you a little more oomph and holding the urine back. These are vaginal cones, and they're weights. You order these online. They used to be about 125 bucks. I think you can pick them up now for like 30 bucks even. But they're usually come with 5 or 6 different sizes or different weights. They're all the same size, but they're heavier and lighter. And this here says Kegel beginners, Kegel experts. You start with the first cone, the lightest one. You place that intravaginally and you try to not to let it to slip out. So it's not easy from what patients tell me. And so you start by sitting and making sure it kind of stays in place, and then you can work on getting to a standing position. And once you're able to master this one, then you move to the next heavier one, then the next heavier one. And you're basically doing your Kegel exercises, except, it's a little bit more active. Now you're doing weight training. It also gives you some feedback, because you can feel if it starts to slip. It gives you that feedback. Oh, I better squeeze a little harder and try to hold that back in. But this is a simple thing that you can do as an aggressive type of Kegel exercise program. Biofeedback is biological feedback, and this is doing the exercises, but again, getting some feedback from your other senses. And so we talked about cones giving you feedback through the sensory receptors, but also you can have visual feedback, you can have audio feedback, and to try to help improve how you're doing the exercises. So this is a home biofeedback system. We used to send to physical therapy, or I used to actually have biofeedback equipment in the office and do it myself. But now you can even just pick this up for, I think, about $125, and you buy it online. And this one's called Kegel. There are a number out there. But this part here goes intravaginal, and this is kind of the antenna. And this hooks up to your cell phone wirelessly. And so when you do your exercise, your phone will show you whether you're doing it correctly and how strong of a contraction you're doing it, and it'll put you through different maneuvers. So it may have hills, and it'll tell you climb the hills, and it will give you the visual feedback from your phone, and also an auditory feedback, and try to walk through those hills. And so it may give you a circular area, and you take that circle and say, make it this big, make it this big, and try to work you through these things. And you're doing your exercises, but it's a little more aggressive. These are over-the-counter inserts. So these are inserted intravaginally, poise and press up. You can buy it at any drugstore. They come in 3 different sizes. You buy the sizing one that has all 3 different sizes, and you try to find out which one fits you best, and then you just buy that size. But if you place this intravaginally, it just puts pressure against the urethra and can decrease some of the leakage. And so if your incontinence isn't too terrible, then this works fine. And so patients oftentimes will say, I'll use this when I go to the gym, or I'll use this on social occasions, but maybe not all the time, and not when they're at home, because they may not want to wear something all the time, and it becomes costly because they're throwaways. But it is something very easy that you can purchase at any drugstore without a prescription. Now, if it becomes to a point where you say, I'm using those too often, I don't want to keep buying them, and that sort of thing, well, we can fit you for a pessary. And there are Pessaries are little silicone devices or rubbery type devices. They come in different shapes and sizes. And these particular type of pessaries have knob at the end, which is to rest against the urethra to put pressure on it, just like the Impressa did. Except this is a permanent device that you can utilize and then pull this out, clean it, but you have full control. It's permanent, so you don't throw it away, and it's more cost effective. But we can fit you for a pessary if you think that might be of assistance. This is showing how the pessary will fit inside the intravaginal area and press against that urethra to try to stabilize that urethra. Urethral bulking agents are some things that we do. It's a type of treatment we do at times as well. It's an office procedure, and the idea is to inject material around the urethra to try to squeeze down that urethra and increase its coaptation to try to get it to close a little tighter. This is showing injection around the urethra from just outside of it and injecting material to bulk it up. This is showing you the beginning picture here where the urethra is kind of open. And then after the injections, the urethra is closed and it's tighter. This is an intraurethral injection. So this is another way of doing it. And this is the way that most of us will do it now, is through a cystoscope and injecting inside the urethra. We do give you numbing medicine in the beginning. And so this is actually very, very easy to do. And it's very, very well tolerated. But this is showing the bulk here from the injection material. And this is showing the 6 o'clock and 10 o'clock have been done. This 2 o'clock has not been done yet. But this is the end result. And again, it tightens that urethra down. The good and the bad, it's a simple office procedure. It's not the best for every type of incontinence. The best patient is someone with the ISD or poor urethra function who have good support and are still leaking. But this is a very simple thing. And it doesn't have very much difficulty to have it done, and usually it's an easy thing to do. And our last subject is going to talk about now surgical procedures for stress incontinence, because there's certainly still a need for this. There are some patients that their incontinence, their stress incontinence is really going to be more severe than the conservative things are going to help, or the conservative things have helped, but just not to the degree that the patient is looking for. And oftentimes surgery for stress incontinence will give you resolution of the problem. In other words, you'll be dry. And so that's depends on what you're looking for, but that oftentimes is something that's that patients would like to have. So this is the old Birch procedure. This is what we used to do on the majority of patients in my early years. And this is an abdominal approach where we make an abdominal incision. And then we dissect down underneath the pubic bone to find the bladder. And we take the tissue besides the urethra and bladder, and we sew that up to a ligament here to support that urethra. So it lifts it and holds it in place. This is another view with the 2 stitches, 2 on each side, and we tie that down and that holds that in place. And this is actual picture of the real anatomy, and it outlines urethra and bladder. That procedure is a very good procedure still. It worked very well. Had cure rates in 80 to 90% of the time. The downside is that it was a fairly large surgery. It, for the most part, was done with an abdominal incision, and it took about an hour and a half to complete. At the time, we used to keep patients in the hospital for about 2 days, and the recovery period was going to be about 6 weeks. And so it was a surgery that patients had to put a lot into to have that relief. And since that time, we've come across other ways of handling it. And so we do very few birches now. The only time that we usually do them is if we're doing an intra-abdominal surgery for something else and that area is already open. So at this point, mid-urethra slings have become standard of care. And what these were brought out in the late 1990s. The advantages here is that it is simple, it is quick. Most of the time they're performed in about 15 minutes. I've done them under 10 minutes. There's minimal tissue dissection. You don't make an abdominal incision at all. There's only a couple of little pokes and that's it. It's outpatient, so you go home right from recovery. There's minimal discomfort. I don't send anyone home with any pain pills. You bounce back, really quick. So it is very advantageous, and patients will say, boy, I'm not sure why I didn't do this earlier, because it was such an easy thing to do, and it worked. It does involve mesh, and so that mesh, it's blown up here in this picture, but it's only the size of a piece of Scotch tape in width. So it's a very small strip of mesh. It's covered in plastic, which reduces the chance for any infection. And it allows us to adjust that mesh underneath the urethra, allowing it to slide so we can tighten it or loosen it. And then we deploy it by removing the plastic. But mesh can be used and can be used safely. This does not help. And these are the ads for the attorneys. I know that most of you have heard about mesh and mesh complications. And there's, oftentimes a real fear of the use of mesh. But I'm here to tell you that you shouldn't be afraid of this. The problem with mesh used in vaginal surgery and pelvic floor surgery is the problem of using transvaginal mesh for prolapse disorders. And what that means is using large sheets of mesh in which we envelope the entire vaginal area, coming in through the vagina, placing the mesh, and then sewing those areas up and holding fallen organs up with that. Those procedures have had problems, and they've had complications. They have had complications requiring a number of surgeries to try to correct the problems. We don't offer those anymore, and we don't, those now are not even made any longer. But that's a different animal than using a small strip of mesh underneath the urethra. And so when we use the urethra slings, they are safe. This is the American Urogynecology Society and Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction, or SUFU. And they've come up with consensus statements, and it states that they are safe and effective. And it is the most studied procedure for incontinence that we've ever had. There's more data on this stuff than any other type of surgery. And it has become standard of care, meaning this is what most everybody in the country would use to do a sling procedure. And the FDA has cleared it and saying that it's safe and effective as well. So it is something that has changed our course of treatment, surgical treatment for stress incontinence. And so it is a huge benefit to modern medicine because it allowed us to treat patients in a very safe and efficient but quick, short, minimally invasive way where they can get back to their life as soon as possible and still have very good results. There are two ways to deliver this mesh. One is through the groin, where we take a needle and pass that through this hole, natural hole in the pelvis, and bring the mesh from side to side like this underneath the urethra. And that's called a TOT sling, which is transobturator sling. These holes are the obturator foramen. So it means transobturator means coming in this direction or from the groin. The second way of delivering the mesh is called a TVT sling, and that's tension-free vaginal tape sling. And that's a retropubic advancement where we come from the abdomen and bring the needles down this way and grab the mesh and pull the mesh up here. So you can see that this angle is a much tighter angle than this. And so there are some differences between these two approaches, but these are the main approaches that you're going to see. First of all, is the mid-urethra slings, meaning TOTs and TVTs, as good as the previous older type of treatment, the Birch? And the answer is yes. So you look at success rates and it's the same. If we look at the TOT sling, it avoids that space, the retropubic space, which is the space where the bladder lies. And so you have much less chance of injury to the bladder. It creates a natural restorative hammock. These are the areas where we need to know our anatomy. This is an area here where vasculature and nerves come in. We're using this area here, and it's a safe area to pass those needles in the sling. And the natural support is in green, and our support from the sling is in red, and you can see how it mimics the natural support. The cure rates are very good, again, from 80 to 90% success, and so it has good efficacy. The next is the TVT sling, which is that retropubic one in the center. And you can either come from the bottom up or from the top down, but it brings that sling into a more tighter type of angle. And I think of it as the TOT or transobturator as the minimal or the minimally invasive type of sling. The TVT would be the moderately invasive. And then a pubovaginal sling, we'll talk about in a minute, is the most invasive in regards to how big of a sling or surgery they are. But they're all very easy, but they have some other issues that we need to talk about. So these needles can be placed if you know your anatomy, where we can find good distances from any vital structures, and so they can be very safely placed. And when we look at TVT versus TOT sling, you have to say, well, is one better than the other? And the answer is no. You're still getting very good success rates on both for simple stress incontinence. And this is a computerized generated study looking at 11 different randomized controlled trials. And again, equal efficacy. They both work equally as well for stress incontinence. If we look at complications, well, it's very hard to injure the bladder with a TOT, but this one you're passing the needle right over the bladder and you can have an injury to the bladder. This is a 5.1% chance of that happening. It's actually a little high, certainly in my hands and most of our hands that people that do this. It's actually much more of an uncommon problem, but you can see that inherently can have a complication of bladder injury much higher. But what does it mean if you pass that needle inadvertently in the bladder? All it means is that if you, assuming you recognize that, you pull it out and re-advance it into a different spot, that part of the bladder will heal up just fine and you're going to feel exactly the same. You're not going to have any issues with it. And anytime we do these procedures, we look to verify that we've not done any harm. And if there was, then we can fix that right then and there, and it's not anything to worry about. Difficulty urinating. It's a little more common with a TVT than a TOT. The need for postoperative medication for some urgency because the bladder did not like you mucking around next to it. Again, a little higher with the TVT than the TOT. And so those are kind of the differences there. But when we compare those two surgeries for standard stress incontinence, again, similar rates of continence, so they both work effectively, less post-op void and dysfunction with the TOT, less urgency with the TOT, fewer bladder perforations with the TOT. So I utilize TOT as my standard, and I use TVT for more special cases, and that is for ISD, or intrinsic sphincteric deficiency. Remember, that stress incontinence with a poorly functioning urethra. Okay, and the thing here is that the TVT is more effective for that diagnosis. And you can see the cure rate here of 87.5 versus only 51% with the TOT. So if you have a diagnosis of ISD, TVT is a better choice. Now we're going to compare pubovaginal sling to the other two mid-urethra slings. And what a pubovaginal sling is, it involves a small incision in the suprapubic area, and we now harvest a graft, and we utilize tissue, and it is wide enough that it covers the mid-urethra, same as the other TVT and TOT slings, except this one's wider where it comes from mid-urethra all the way to the bladder. So it is a big backboard. Instead of a thin backboard for the urethra to hit, it is a very wide backboard. So when the urethra hits it, it helps it really close. And so it's for more severe incontinence, a severe ISD patient, or a patient that the TVT just wasn't enough to hold that urine back. And it's a more aggressive type of sling, but it's still a very easy procedure for a patient to go through. Very little discomfort because the incision is not large, but it has very similar cure rates to the TVT for the most part. And again, the TOT for ISD does not work as well. So when we do a pubovaginal sling, we either can use autologous graft, which is your tissue. Allograft is cadaver or a dead person's tissue, or xenograft is an animal biologic, pig skin, calf skin. And those are the three ways of doing it. Typically, I will use autologous tissue from your fascia in the abdomen. And so we make a small incision, we bring it down to the fascia, and then we separate a small area, typically around 2 or 2.5 centimeters by 8 centimeters, and we cut that off and then repair that area. We place suture on the ends of the graft, and then we use a needle device to pass through the area into the vaginal area and grab the end of the suture and pull the suture up. And so then we can tie that across the midline, and that's going to give the support. And so it's tied, and it's a nice wide big sling, and that will support that bladder. Now, this one again is the most aggressive type of sling. Why? Well, the wound infection is much more common with this. You can get infection because you were working vaginal and abdominal both. You can get an incisional hernia because you took a piece of that fascia away. Doesn't happen very often, but that would be another reason why you wouldn't do this for simple stress incontinence, and you're doing it for selected cases. And the biggest thing is difficulty urinating. So there's a much higher problem with urination after this in regards to or compared to the other type of slings with not as large of an area. This one is a little hard to get the urine over that large sling sometimes. And so those would be the downsides to it. But in summary, though, we have a lot in our armamentarium to offer, and there are a lot of very simple type of things that can be done. And first of all, there are conservative things for both overactive bladder and stress urinary incontinence. And there are more advanced treatments for both of those as well. And for the most part, those advanced treatments are very easy, minimally invasive type of treatments. And they're typically with very good track record and very successful. So there's a lot to offer patients with urinary incontinence. And I'm available for questions.
Thank you. That was a lot of great information. We do have a question. Is there an age at which no certain procedures would be considered?
No, I don't think there's an age. I think that it matters more about a patient's health. And so as long as you're healthy enough to undergo a procedure, then, we would be okay with doing it. We sometimes will ask your primary doctor to give clearance, and just to make sure that there aren't any issues that would be a problem for you to have anesthesia. But, if we talk about the surgeries for stress incontinence, we're talking about a 10 to 15 minute procedure. And it doesn't have to even be under general. We could do it under a spinal. If we had to, we could do it under local. And so we're talking about very minor procedures. So it's very unusual for someone not to be able to grant clearance to a patient because it's such a minor procedure. So I would say no. We've done. The oldest person I've taken for a sling is 93 years old, and she did very well. We don't want to take, anybody with health issues and morbidities to the operating room if we don't have to, but this involves quality of life. And so if a patient's having a problem that they say, boy, I don't want to live like this, and I'm willing to accept a very small risk to have this thing done, then by all means, I think that that's acceptable.
How long does a bladder sling typically last, or is there any complications along both lines?
The length that the results last, the real answer to that is I don't know. The reason I say that is because we don't carry studies out 10, 20, and 30 years. And that's the real question. Is it going to last the rest of my lifetime, or am I going to have this over? I can tell you this: when we use a Prolene mesh sling, they don't go away. That's permanent material, and that support should not change, meaning it stays exactly where it is. And so if there is some recurrence of leakage, it typically is because something has changed. So either your condition has worsened considerably, the urethra function is now much worse, you develop bladder spasms, those type of things. But we do know that when we quote the studies of 80 to 90%, that's 5-year data. We also know that, it's more toward the 90% in the beginning and more in the mid 80s by the 5 years. So there is a small kind of decline, and that's people developing other things. And we think that decline probably continues the 10, 20, 30 years down the road, but it's not something that you fall off the cliff. So the majority of patients are holding up very nicely.
We have a specific question here. Years ago, I had a bulking agent injected into the area between the anus and vagina that consisted of very small pellets. This worked great, but the pellets got reabsorbed into the body and it needed to be done again, about every 6 months or so. Do they still use this procedure now or not?
Well, I mean, that procedure that patient is, or that person is talking about is not for urinary incontinence. that's fecal incontinence.
Okay.
That's something called Celesta. It's still used. I don't use it personally because there are some issues with infection with that. But it's similar to the bulking agents that we do periurethral or transurethral. And yes, they don't last forever. That's the downside to them. I forgot to mention that, is that they will eventually be absorbed, and you'll have to repeat it. And in my experience, the transurethral bulking usually lasts anywhere from 6 to 9 months. And so you do have to come back and get a booster, typically in that time frame.
And we did get another comment from that person. It was, she had that procedure done for urinary stress incontinence, and it really worked well, she said.
Okay, yeah. One thing I failed to present, and I know this is not part of the talk, but the person who just said that they had the injection around the anal area for fecal incontinence, neuromodulation is a treatment for that as well. And 70 to 80% of patients will have at least moderate to marked improvement, and about 50% of the patients, 45 to 50, will get cured from that too. And that's a whole different subject. But that person, if she's still having issues with that, there is some other things available.
Great. Are the procedures you talked about covered by Medicare or in insurance?
Yeah, typically the answer is yes. We do insurance checks on the Botox, but typically Medicare does pick it up. Medicare pays for the surgeries. They pay for the bulking. They pay for neuromodulation. So the answer is yes. Medicare typically pays for these type of things.
Very good. I believe that was our last question. So, so with that, this has been a lot of really great information. Thank you so much, Dr. Agosta, for spending this time with us today. We really appreciate it.
Thanks so much for having me.
Yeah. Hope everyone has a great day. Thank you.
Okay.